Diabetes mellitus, it is the most frequently occurring condition in the developing countries, which accounts for 1% for the morbidity and mortality rate in developing countries also. And usually it is a condition which usually progresses in nature, and so its control is very important for a patient. So coming to the definition of diabetes mellitus, it has been defined as a heterogeneous metabolic disorder, and it is characterized by a common feature, that is the presence of chronic hyperglycemia, increase in the blood glucose levels, and along with that there's also disturbance in the carbohydrate, fat as well as protein metabolism. So it is called as heterogeneous because there are a lot of conditions being associated in this condition of compromised condition of a patient. And broadly, it is described into four types. Coming to the type 1 diabetes mellitus, it was previously also known as juvenile onset diabetes mellitus, since it was occurring in an early age group of below 35 to 40 years. And it was also known as insulin dependent diabetes mellitus, since the patients in type 1 diabetes mellitus require the replacement of insulin for the levels of blood glucose level. And this type 1 diabetes mellitus, it could be further classified into type 1A or type 1B. And type 1A diabetes mellitus is an immune-mediated diabetes mellitus. It is so-called immune-mediated because since insulin is being secreted and released by certain pancreatic cells, and among the pancreatic cells, it is the beta cells in pancreas which release this insulin. So there are autoimmune antibodies which are formed within the body, and this results in the destruction of this beta pancreatic cells. So it is known as immune mediated. Coming to the idiopathic, it is known as idiopathic because there is no specific presence of autoimmune markers such as seen in type 1A diabetes mellitus, but there is tendency to formation of ketosis. Coming to type 2 diabetes mellitus, it is also known as late onset diabetes mellitus or insulin dependent independent diabetes mellitus. In these patients, there was a hypoglycemia seen, and these patients do not particularly require the insulin replacement, but rather there is requirement of the control of the conditions of obesity or the diet and requirement of exercise in these patients. Next set of diabetes mellitus is the gestational diabetes mellitus, which is usually acquired in the period of pregnancy or immediately after delivery. We see that the patients are recovered, but there are chances for these patients in future to develop diabetes mellitus. It is usually because of an hormonal imbalance during the pregnancy time. And the other specific types of diabetes include the first one, they constitute of about up to 10%, and they are genetic defect of the beta cell function, that is as previously discussed, destruction of the beta cells which are involved in the insulin production. There are changes genetically, that is congenital defects are seen, so it could result in diabetes. Otherwise also genetic defect in insulin action, that is any receptors against to this insulin action, can also result in diabetes. And disease of the exocrine pancreas, a disease of the exocrine pancreas, that is an inflammatory condition of the pancreas known as pancreatitis, or otherwise in post-pancreatectomy also can be one of the reasons for diabetes mellitus. And endocrinopathies such as in conditions of Cushing syndrome or acromegaly, we find presence of diabetes mellitus. And then the drugs or chemical induced presence of steroids, patients taking steroids or any hormonal imbalances can also result in diabetes mellitus. And infections such as rubella, cytomegalovirus are also one of the etiological agents causing diabetes mellitus. And the uncommon forms of immune-mediated diabetes mellitus, that is, it could be anti-receptors to the insulin receptor substrates, which result in failure in the action and cause the diabetes mellitus. And the other genetic syndromes, amongst them it is a Down syndrome, Klinefelter syndrome or Turner syndrome, which help in developing the condition of diabetes mellitus. Coming to the pathogenesis, usually we find that in a diabetic mellitus patient, we find that there's reduced in the insulin secretion, and this insulin secretion, as it is the regulation of the insulin is being stimulated by the presence of the glucose levels in the body. So decrease in the glucose utilization by the body, or otherwise increased glucose production, can alter the insulin secretion release as well as its action, which could result in diabetes mellitus. So there is a pathogenesis in brief. So as since insulin is a major substrate which helps in maintenance of the blood glucose level, and the glucose helps in regulating this insulin metabolism, which is important to know how insulin is synthesized, how it is released, and how it starts showing its action. So for that, firstly, there are three stages, that is the insulin synthesis. Usually insulin, it is synthesized in the beta cells of the pancreas, where it is initially synthesized as a pre-pro-insulin, which is a amino acid, and this amino acid with the degradation of the terminal amino peptides results in the formation of pro-insulin. And this pro-insulin with the further addition of the amino peptides results in the formation of A insulin chains and B insulin chains. And this A insulin chains and B insulin chains they are interlinked to each other with a bond known as C peptide bond. And this C peptide bond is so resistant that though in cases of any damages, since insulin metabolism also occurs in liver, and when there are any damages occurring to this chains, A and B chains might get degraded, but C, it is so resistant to the liver degeneration or any damages that it is being used as a marker for presence of the insulin secretion and its action in the body. So coming to the mechanism of insulin, once this insulin is formed, the presence of hypoglycemic conditions, that is levels below 70 mg per deciliter of the blood glucose levels in the body, they cause the transport of the glucose transporter receptor or the glucose transporter into the beta cell. Once this glucose transporter is reached into the beta cell, it is being activated by an enzyme known as glucokinase. This glucokinase causes a transformation of the glucose transpose receptor. It causes a conversion into its glucose 6 phosphatase. This glucose 6 phosphatase conversion also results in production of ATP. It generates ATP, and this generation of ATP further is being followed by the alteration in the ion channel activity. Since ion channel activity is responsible for the outflux and influx of the respective potassium and the calcium ions, there's alteration also in this ion chain activity, where there's too much of influx of the calcium ions within the body, and there's excess of potassium being released out of the body, where this could be one of the stimulus for the release of the insulin from the beta cells extracellularly, that is out of the pancreas. So once this results in the release of the this release causes the release of the insulin. So this is a mechanism of insulin release, showing the influx of the movement of the glucose transporter 2, and where it is being converted into glucose 6 phosphate by releasing the ATP production, generating the ATP and altering the ion chain activity, where there is efflux of the potassium and influx of the calcium, whereby this causes the exocytosis of the stored insulin from the pancreatic beta cells. And so once if the insulin is being released extracellularly, it goes and this insulin starts showing its effect on the target cells, and the target cells usually consist of insulin receptor substrate 1 and substrate 2. This insulin receptor substrate 1 and substrate 2, once they get bond with the insulin, they start mediating the intracellular mechanism, where this intracellular mechanism with the further phosphorylation and dephosphorylation actions starts showing the anabolic actions and the mitogenic actions. The mitogenic actions include the MEP kinase pathway, whereas the anabolic actions, which regulate the process of blood sugar level, that is in the gluconeogenesis, lipolysis, and also protein synthesis, and the oxidation of the ketones. So these are the processes which are being seen in the anabolic actions, and this completes the insulin action and how insulin helps in regulating the blood glucose levels. So coming to the type 1 diabetes and type 2 diabetes mellitus and the pathogenesis. Usually in pathogenesis of type 1 diabetes mellitus, it shows there are factors such as genetic susceptibility, autoimmune factors, and the environmental factors. Whereas in the pathogenesis of type 2 diabetes mellitus, we see that there are genetic factors, constitutional factors, insulin resistance, and impaired insulin secretion, as well as impaired increased hepatic glucose synthesis, which cause the pathogenesis of type 2 diabetes mellitus. Coming in detail, the genetic susceptibility in type 1 diabetes mellitus, which is the reason to cause this, there's usually they are found in certain studies that there's concurrence in twins of 50%, which explains the genetic susceptibility for development of type 1 diabetes mellitus. Other than that, there was also presence of association of HLA associated, that is a human leukocyte antigen complex, which was being seen in chromosome C, and this human leukocyte antigen complex was HLA D3 and D4, which was being observed. Other than that, this is also being mediated also because of the environmental factors. It could be viral, chemical, or otherwise geographic. That is a racial species, that is the African Americans were more commonly showing type 1 diabetes mellitus when compared to the white people, and otherwise the chemicals also, that is being based on the occupation exposure, also helps in development of type 1 diabetes mellitus. The viral, they are the cytomegaloviruses and the rubella, they also help in development of the type 1 diabetes mellitus. Other than this, the autoimmune factors, that is the islet cell antibodies to the cells, which usually helps in insulin synthesis, also and one of the cause for type 1 diabetes mellitus, and the selective beta cell destruction because of the autoimmune antibodies to this beta cell results in type 1 diabetes mellitus. Otherwise, any insults to the beta cells which are actually involved in synthesis also help in development of type 1 diabetes mellitus. Coming to the development of type 2, usually we see in type 2 diabetes mellitus there's presence of genetic factors as well as constitutional factors. Genetic factors, we see that there's concordance in similarly twins and 50% in 50% of the twins as in type 1, and other than that, both the parents have shown to be diabetics in case of type 2 diabetes mellitus in the offspring. And the constitutional factors, other than that, obesity could also be a contributing factor, and hypertension and presence of low physical activity, loss of exercise to the human body can also help in development of diabetes mellitus. And this genetic factors and the constitutional factors, they might also alter the insulin secretion. They result in decrease in the insulin secretion, and they also cause the insulin resistance. The presence of increase in the harmful lipids, that is the low density lipids, increase in amount, whereas the high density lipids, they are reduced in amount, which are usually protective in mechanism. There's alteration, so this could also be one of the reasons for decrease in the insulin secretion. Other than that, there's also glucose toxicity because of the increased hyperglycemic levels. Insulin resistance, that is the receptors and the post-receptor defects, may cause the impaired glucose utilization, which could result in type 2 diabetes mellitus, mediating with the increased blood sugar levels. This is a type 2 diabetes mellitus. Coming to the differences in type 1 and type 2 diabetes mellitus, usually the frequency, usually we find that type 1 diabetes mellitus is less common when compared to type 2, and the age and type of onset, usually type 1, it occurs below the age group of 35 to 40, whereas type 2, it occurs as the age progresses above 40 years, and the type of onset, it is usually insidious and severe in onset, whereas it is abrupt and prolonged in onset, type 2 diabetes mellitus. And coming to the weight, usually the patient weighs normal in type 1, whereas in type 2, usually the patients are normal, otherwise obese or overweight. And the presence of association of HLA associated human leukocyte associated complexes has been found in type 1 diabetes mellitus. They were HLA D3 and D4, whereas there was no such association in type 2 diabetes mellitus, and there was also genetic locus. It was identified in chromosome 6 in type 2 diabetes mellitus, whereas in type 1 there was no such identification of genetic locus. Coming to the family history, there was less family history, there was less chances of the family history, but there was concordance in 50% of the twins, whereas in type 1 diabetes mellitus, whereas in type 2 diabetes mellitus, we have seen there was a definite family history with concordance in 50% of the twins. Coming to the pathogenesis, it is usually because of the autoimmune destruction, or otherwise it could be idiopathic in nature in type 1, whereas in type 2, it is because of the altered insulin levels in the type 2 diabetes mellitus, which results in hyperglycemia. And the islet cell antibodies, they were seen in case of type 1 diabetes mellitus with insulitis, whereas in type 2 there were no such autoantibodies, but there was insulitis in chronic cases. Coming to the blood insulin levels, usually There was hypoglycemia in both the cases, but in type 2 diabetes mellitus there was increased. Amyloidosis is less common, but in chronic cases of type 2 diabetes mellitus, it was seen. Now, coming to the clinical management, usually patient is advised with insulin replacement in type 1 diabetes mellitus. In type 2 diabetes mellitus, patient was advised with oral drugs, a diet, exercise, as well as in chronic cases, insulin replacement. Acute complications, usually we see ketoacidosis and diabetic coma in cases of diabetes mellitus. Coming to the pathophysiology of diabetes mellitus, it is usually majorly because insulin deficiency is a major cause for diabetes mellitus, and this insulin deficiency results in high increase in the blood glucose levels. That is, this increased blood glucose levels shows its manifestation where the glucose is being excreted in the urine, which is known as glycosuria. Along with that, this glycosuria is also which also mediates catabolism reactions and anabolism reactions, where we see that in catabolism reactions there is increase in the lipolysis, that is destruction of the lipids. This destruction of the lipids results in increased release of free fatty acids. This free fatty acids are being converted to ketone bodies, which is being mediated by an enzyme known as acetyl enzyme CoAs. And this ketoacidosis finally results in death of the patients. Whereas in anabolic reactions, we see that there's osmotic diuresis, that is the osmosis in the blood fluid, the fluids, body fluids, there's being altered, and this alteration results in dehydration. That is, there's loss of body fluids, and this loss of body fluids is associated not only with the body fluids, along with the electrolytes which are present in the body fluids are also being lost, and this loss or imbalance in the body fluids results in shock and finally results in coma of the patients, which is known as diabetic coma, and which both of these ketoacidosis and diabetic coma, if not treated in a proper situation in an earlier phase, then results in death of the patient. This is the pathophysiology of diabetes mellitus. So coming to the main symptoms, what we find is usually diabetes mellitus is being accompanied with polydipsia, increase in thirst, polyphagia, increased thirst, polyuria, presence of increased urinary excretion are the major pathogens symptoms which are seen in a patient with diabetes. Other than that, we see it centrally affecting, that is the nervous system, polydipsia and polyphagia being associated. Other than that, lethargy and stupor are more common, where lethargy, it is a weakness because of the loss of energy, and stupor, that is the alteration in the mental physical activity of the patient. And systemically, if there's weight loss of the patient and the respiratory system which is affected, that we see there's presence of cosmal breathing, that is prolonged and longer breathing, deeper breathing we see in these patients. And the breath results a smell of acetone, that it releases a fruity disorder. And the eyes, we usually see there's blurred vision, which could also result in cataract and glaucoma in the patient, that is complete loss of vision. And coming to the gastrointestinal tract, they might result in nausea, vomiting. This because of the loss in the fluid levels in cases of anabolic reactions, where along with that associated with that we see patient frequently complaining of abdominal pain. And urinary tract infections, we see polyuria, which is a commonly given complaint by the patient. Along with that, because of the increase in the blood glucose levels, the glucose is being excreted from the urine. Coming to the long-term complications, this includes the vascular, metabolic, as well as the immune complications. In the vascular complications, there could be macrovascular changes or the microvascular changes. Among the macrovascular changes, we see atherosclerosis, that is, there's changes in the blood vessel wall, that is, there's thickening or the formation of fibrosis. This fibrosis and thickening forms one of the regulatory factor for it regulates the formation of infarcts, that is the blood vessels or the thrombotic emboli, which usually are the deposits formed within the blood vessel because of the alteration in the blood vessel wall, that is the impaired blood flow, results in formation of thrombi. In this thrombi, when they are detached and flow throughout the body fluids, they are known as infarcts. And so we can see infarcts in cases of vascular changes in diabetics. Along with that, we find gangrene of the lower extremities, which is seen in most of the diabetic individuals, where it is also known as diabetic foot, that there is incomplete or inadequate supply of the blood to that particular affected area, which results in change in the color of the tissue and even the functional activity. So these are the macrovascular changes. Coming to the microvascular change, usually we find microangiopathy, that is the thickening of the basement membrane. This thickening of the basement membrane, it could be seen in the neuropathy, that is neuropathy, that is in the nervous system. There could where we can see squamous cell degeneration or the nerve demyelination can be seen in cases of neuropathy. Otherwise, in nephropathy, where we see alteration in the portal veins or the renal veins, which are actually involved in excretion, this brings about changes. And retinopathy, that is we can see hemorrhagic, that is blood excluding out from the veins, which could also result in blurred vision or completely loss of the vision in cases of long-term complications. Coming to the metabolic complications, so this could be protein glycolization, that is there could be lesions formed within the aorta or the eyes, or otherwise in the kidney and the nerves can be seen in long-term complications. When it involves the sorbitol, then we can see the basement membrane thickening as explained in the vascular changes in the microangiopathy. Similarly, we see the changes even because of the sorbitol, presence of sorbitol also, that is in neuropathy, nephropathy and retinopathy can be seen. Coming into the immune mechanism, where we see when the diabetes mellitus is because of the autoimmune destruction, because of the defective in the cell-mediated immune response, this could result in infections, that it could form one of the contributing factors for the development of more of infections. Among these infections, we find there's tuberculosis, urinary tract infections and pneumonia, which are the most major complications which are seen in untreated cases of long-term diabetes. Other than that, we also see there's defective polymorphonuclear functions because of the changes in the blood glucose level. They form one of the contributing factors for the development of fungal as well as bacterial infections. These are the long-term complications in diabetes mellitus. So coming to the secondary systemic complications, usually we see that there's cataract, retinopathy, that is blood glucose levels, they cause the microangiopathy in the blood vessels of the eyes, which results in hemorrhagic reticular hemorrhage, or otherwise the hemorrhage from the lens, results which could result in finally blurred vision, otherwise completely loss of vision. And otherwise in the heart, it would cause the coronary atherosclerosis, that is the thickening of the arterial blood valves, and could result in congestive cardiac failure. And coming to the autonomic dysfunction, it could also affect the gastrointestinal tract by causing the abdominal pains, and which could result in polyuria and polydipsia also. And the other than that, we find the diabetic nephropathy, that is we find that these patients, usually we find there's also changes in the portal vein, that is because of the thickening of the basement membrane. In this renal veins, we find the diabetic nephropathy. The diabetic neuropathy, that is the extremities, they show changes, that is the diseases affecting the extremities, that is it could be the veins or the arteries. Coming to the diabetic ulcer, so in case of diabetes, because of the increase in the blood sugar levels, it produces an environment or a proper contributing atmosphere for the growth of the microbial infections, which might result in formation of the ulcer. Coming to the dry gangrene, which is the most common feature seen in diabetic patients, we see that because of the loss of the blood supply to the particular area, that is most commonly to the lower limbs, which is known as diabetic foot, which might result in dry gangrene, where usually in diabetics it results in non-healing, so it is supposed to be amputated, that is it is removed from the ascending structures. These are these are the secondary systemic complications in case of diabetes mellitus. Coming to the diagnosis, usually it is easy to diagnose a patient with a symptomatic showing us some proper symptoms, but in an asymptomatic patient it is difficult to diagnose diabetes mellitus because they rather go asymptomatic, and they usually diagnosed only with particular diagnostic aids. And amongst them, urine testing is one of the cheap and convenient method of diagnostic aid, but it is not used for the confirmation. Rather, it can be used in screening or in surveys conducted in a large populations. So coming to that, first urine test where the patient's urine is being collected, and this patient is advised to where the patient's urine is being collected, and we see for the presence of glucosuria, that is presence of glucose within the urine, and this is being diagnosed by Benedict's test or otherwise dipstick's test. Benedict test helps in diagnosing and identifying the presence of glucose in the urine, whereas dipstick's test, where the strip is being placed and change of its color into purple, helps in identifying that there is presence of glucose, and this gives a diagnosis of presence of diabetic mellitus. Coming to ketonuria, usually it is done to detect the presence of ketone bodies within the blood sugar levels, and this is done by Rothera's test, where presence of the ketone body can also help in giving a diagnosis of diabetes mellitus. Coming to a single blood sugar estimation, it is usually done by Fallen-Wu method or otherwise Samuki test or otherwise O-Taurin test, where so blood sugar method is estimated when the patients are where patients are detected that even after fasting blood glucose level of presence of above 126 mg per deciliter is being identified, then the patient is said to be diabetic in the single blood sugar estimation. One of the diagnostic aid which helps in detecting that the patient with fasting blood sugar levels of above 126 mg DL are supposed to be diagnosed as diabetics. Coming to screening by fasting glucose test, it is one of the important diagnostic tests in case of type 2 diabetes mellitus, since the patients are mostly asymptomatic. And there's an advised screening test for patients for every human being above 45 years of age, though they mean to be diabetic or no, because since some conditions such as type 2 diabetes mellitus, the symptoms might appear 10 years after the diabetes has already occurred. So it is important that every patient above 45 years is supposed to go for a regular single fast screening by fasting glucose test every 3 years. So this is one of the fasting glucose test. Coming to the major importantly used oral glucose tolerance test, is a test to detect the blood sugar levels based on the fasting levels as well as postprandial. The patient which is being advised for a diagnosis of oral glucose tolerance test is being advised to be on a high calorie diet for 3 days, and then the patient is advised to be on fasting 8 hours earlier before the test is being done. And once the patient arrives to the lab, then the diagnosis, the following lab procedures are carried out as follows: that the patient is being given the fasting blood sugar level is being collected from the patient. Once the fasting blood sugar level is collected, and the patient is given a 75 grams of glucose mixed in 300 ml of diluted water, and this is the patient is taken supposed to intake this diluted water with glucose, and the blood and urine are being collected every half an hour for 2 hours at least. Then once they are collected, and the diagnosis of an diabetes mellitus can be given. Suppose the fasting for that is fasting a patient who has been fasted 8 hours earlier, when it shows the fasting blood glucose levels of less than 100 mg per day, then it is known that patient is normal. Suppose the blood glucose levels are 100 to 125 milligrams per deciliter, then is known as impaired fasting glucose. And if it is more than 126 or 126, then the patient is said to be a diabetic. And 2 hours after the given oral glucose load, then if the normal postprandial, it is known as postprandial because the patient is being given glucose levels. So it is known as normal postprandial glucose tolerance test, and this is said to be normal if the patient shows blood glucose levels of less than 140 per mg/dl. And if the blood glucose levels are 140 to 199 mg per dl, then it is known as impaired postprandial glucose tolerance. Then, if the patient is known as showing levels of 200 or more, then it is known patient as diabetic. Coming to the random levels, that is a patient who has not fasted and is not being given any glucose overload, and randomly the blood glucose is being collected, and if it is being the blood glucose levels are 200 or more, then it is known as patient is diabetic mellitus. This is a oral diagnosis by oral glucose tolerance test. Coming to hypertension, hypertension is the leading cause, or is also one of the leading cause of deaths in the developing countries, because since it is a condition because in a developing countries who have been exposed to stress or the developing changing lifestyles. So hypertension can be defined as it is a high blood pressure or the arterial hypertension for a long. It is a long-term medical condition in which the blood pressure in the arteries is persistently elevated. That is a blood pressure is usually maintained by a normal human being is elevated. It is something abnormal, and this is usually measured with the systolic pressure and the diastolic pressure. Systolic pressure is the pressure when the left ventricles contract, whereas diastolic pressure is a pressure being exerted as soon as the left ventricles relax. So it is a systolic pressure known as maximum pressure, diastolic pressure as the minimum pressure, and the normal blood pressure of the systolic blood pressure is 100 to 140 mm per mercury, whereas diastolic is 60 to 90 mmHg. And so there's a picture which shows that when the heart is being overloaded, then it pumps too much of blood, by which the blood pressure is being increased. That is, has increased in the over workload. And if suppose it is untreated, it results in the atherosclerosis, that is changes in the arterial wall because of the increased blood being circulated, and this results in congestive cardiac failure. This is the main pathogenesis for resulting in death in patients with hypertension. Coming to the classification of hypertension, it could be primary or essential hypertension, which is seen in 80 to 95% of the cases with an unknown cause or unknown etiology. Patients start developing hypertension, whereas secondary hypertension, it is secondary to any diseases or any organs or any problems, such as it could be because, and it is more commonly seen in African Americans than in whites, and this secondary hypertension, it is usually because of the because of the change in the lifestyle. It could be because of obesity or stressed occupation, or because of the developing changes in the lifestyle. Coming to the benign hypertension, it is usually the hypertension which usually rises slowly but not at a time, whereas malignant hypertension, usually we see that the patient suddenly develops, and the hypertension could be 200 systolic mmHg and 140 mmHg, so the diastolic. So these are the conditions which we see in the types of hypertension, that is the primary, secondary, benign and malignant. Coming to the reasons why the essential hypertension occurs, in 90% of the cases which show essential hypertension with unknown regions, it usually shows genetic factors. That is usually it could be with a proper family history and concordance in identical twins, and also because of the racial and environmental factors. As already discussed, it is more common in African Americans than in whites, and the environmental factors such as conditions like stress, obesity and skilled occupations, and risks which modify the course are age. If it has been neglected in the younger age, then it could result in progressive hypertension, and it is also if it is untreated, and even in a older age group, it can also be progressive. So these are the risk factors which modify the course. Other than that, the risk factors such as already patient being having a condition of diabetes mellitus, smoking, they can also progress the condition of essential hypertension. Coming to secondary hypertension, which is seen in 10 to 10% of the cases, it could be because of the changes in the renal, because of the renovascular changes, since renin-angiotensin mechanism is a chief mechanism which helps in releasing certain catecholamines, and which in turn alter the blood pressure. So renal changes such as the renovascular changes or renal parenchymal disease have said to be one of the causing factors in secondary hypertension. And coming to the endocrine, it could be because of the adrenocortical hyperfunction, because of the increased release of the adrenocortical hormone from the cortex or the adrenal gland, because of the activated angiotensinogen, can also be one of the reasons for secondary hypertension. Other than that, in conditions such as hyperparathyroidism and intake of oral contraceptives can also help in developing secondary hypertension. And coming to the aorta, that is in the vasculature, when this coarctation of the aorta can also develop hypertension because of the altered blood circulation, and neurogenic because of the decrease in cardiac output, which in turn indirectly attacks the cerebral system, can also cause neuropathy, that is disease in the neurological system, and causes one of the causative factor for developing secondary hypertension. So normally the systolic pressure is less than 120 and the diastolic pressure is less than 120. That is 120 by 80 is considered to be a normal blood pressure, but patient is said to be prehypertensive when the systolic pressure it ranges from 120 to 139 and diastolic from 80 to 89. And patient is said to be hypertension stage 1 when it is 140 to 159 and 90 to 99 in diastolic, and stage 2 when the systolic pressure is more than 160 mmHg and more than 100 diastolic mmHg. And isolated systolic hypertensive patients are those which have systolic pressure of greater than 140 and diastolic pressure of less than 90. And malignant hypertension, that is sudden rise in the hypertension of more than 200 mmHg of systolic pressure and more than 140 mmHg of diastolic pressure is said to be hypertensive, malignant hypertension. So this is a hypertension. And coming to the main pathogenesis, so since blood pressure is mainly based on the arterial pressure, that is the cardiac output by this arterial pressure, and the peripheral resistance, these two are said to be the main pathogenesis which help in developing the hypertension. The cardiac output in turn, there's alteration in the cardiac output, it also alters the stroke volume and the heart rate. Because of the increase in the stroke volume, the heart rate also increases, and the stroke volume causes the myocardial contractility, that is the contraction of the myocardial system. The entire musculature of the heart is also altered, and this change in the contraction is also mediated with the changes in the size of the vascular component. This occurs by the cardiac output. Coming to the peripheral resistance, usually the peripheral resistance, suppose as increase or decrease in the cardiac output, this changes the vascular structure because of the amount of blood being flowed in the circulation, and this also serves in changing the vascular function. This is said to be the reason for development of, in general, of the hypertension. It could be essential, malignant, secondary or benign hypertension. Coming to the pathogenic mechanisms in the essential hypertension, usually we see this presence of high plasma levels of the catecholaminates because of the alteration in the renin-angiotensin mechanism, which is a major mechanism which is being altered by the decreased cardiac output, which decreases the glomerular filtrate rate. And other than that, this high level of plasma level catecholamines also in turn may affect the levels of blood volume, which might increase the blood volume. And this increase in the blood volume, it is actually mediated with increase in the cardiac output. Other than that, we see that in essential hypertension, there is low renin low presence of renin hormone, whereas in essential there is also presence of high renin in case of other types of hypertension. So these are the pathogenic mechanisms in essential hypertension. Coming to the secondary hypertension, we see that the renal hypertension is seen, that is the activation of the renin-angiotensin system. So coming to the renin-angiotensin system, which is one of the chief mechanism which alters, which is the reason for development of secondary hypertension. So when the condition is of decreased cardiac output, this decreased cardiac output usually stimulates the renal hypoischemia, that is there's decrease in the blood supply to the renal system. This decreased renal ischemia further is being followed by decrease in the glomerular filtrate rate. This glomerular filtrate rate usually causes the activation, that is this glomerular filtrate rate, since it decreases, there's also a decrease in the low fluid flow and low sodium concentration, as the first picture shows. Once this low sodium concentration, it acts as a stimuli for the secretion of renin, which is present in the juxtaglomerular cells in the kidney. This This stimulation of the release of the renin from the juxtaglomeralar cells causes the renin to be released and reach the kidneys, where in the kidneys this renin acts on angiotensin 1, and it causes the activation angiotensinogen. It converts the angiotensinogen into angiotensin 1 because of its enzymatic action. Once this angiotensin 1 is being converted and it is not unstable in the kidney, it is being moved, it is being transported to the lung, where in the lung this angiotensinogen 1 is being acted upon by an enzyme known as convertase, which is already present in the lung. This is also known as angiotensin converting enzyme, which is present in the pulmonary blood. This converts angiotensinogen 1 into angiotensinogen 2. This angiotensinogen 2, it actually shows its function, that is, it usually functions in stimulating the adrenal cortex to release a hormone known as aldosterone. This aldosterone in turn helps in maintaining the body fluid levels and the electrolytes within it, whereby it causes the movement, that is, it stimulates the sodium uptake by the cells which are present in distal convoluted tubules as well as in the collecting ducts. Thereby there is reabsorption of sodium by these structures, and thereby it also helps in maintaining the retention of the water, that is, it also helps in water reabsorption. That is what happens in renin-angiotensin mechanism. So this helps in maintaining the hypertension, but since it is altered in hypertension, this results in secondary hypertension. So what is sodium water retention? As already explained, activation of this renin-angiotensin mechanism helps in retention of the sodium water reabsorption and results in release, causes the alteration in the blood pressure, and also the release of vasodepressor material because of the altered body fluids and the electrolytes. Vasodepressor materials such as the prostaglandins and the platelet activating factors also show its effect on the production of secondary hypertension. Other than that, there is endocrine hypertension can be seen in cases of conditions such as Cushing syndrome and acromegaly, which patients start developing hypertension secondary to these diseases. And the coarctation of aorta, when this coarctation of aorta, usually the systolic blood pressure is altered in the upper half of the body, and consequently when the systolic blood pressure is being altered, there is also changes in the diastolic circulation. Coming to the neurogenic factors which involved in secondary hypertension, usually in psychogenesis polynephritis, we see that these in turn develop secondary hypertension. So coming to the main complications, what is seen in high blood pressure is majorly involving the brain. We see that the cerebrovascular accident or the strokes happen because of the alteration in the blood pressure, and this might manifest as hypertensive encephalopathy, that is a disease of the nervous system, central nervous system, which might manifest as confusion, headache and convulsion. And when it affects the eyes, it causes a hyperretinopathy. There is retinal hemorrhages which will cause in the blindness and blurred, in mild cases it is blurred vision, but in severe cases it is blindness and cataract can also be result. When it affects the heart, then it results in myocardial infarction, that is improper blood supply because of the decrease in the cardiac output, and associated with it is hypertensive cardiomyopathy because of the alteration in the cardiac output, and this results in heart failure. Other than that, we see that there's elevated sugar levels also being seen, which could be one of the contributing factors for hypertension to progress in nature. And in kidneys, it usually shows hypertensive nephropathy because of the alteration in the renin-angiotensin mechanism. It might cause nephropathy, that is disease of the parts of the kidney, and results in chronic renal failure. These are the complications which are seen because of the high blood pressure.